Hello, and welcome to Black Doctors Speak. Again, your Tuesday night show where you get to speak directly to Black doctors from around the. Once again, I am Ellis Dean, a senior project manager with BlackDoctor.org, and we are all here with the incomparable Dr. Michael Lenore. How are you doing this evening, Dr. Lenore?
Each week you find a different adjective to introduce me. But
I got to keep your toes, sir. I got to keep you on your toes.
We have a great show planned for you today. First, we're going to talk with our new co-host, Dr. Donna Carey. We're going to introduce her. She will be with us for the duration of our programs. Some programs we'll do together, some programs she'll do by herself. But she's an outstanding physician, a great reputation in the Bay Area, and has her own program called Walking and Talking, Drinking with Donna, whatever. She'll tell us exactly what that all means. But she's an outstanding person, and I think she'll give you help us get a lot of good information. As always, our program is designed for you to call or talk or text or get in the chat room and ask us questions. So today we're going to talk, we're going to review where we are with the coronavirus. We're also going to talk about asthma. So we just happen to be on the cutting edge. You're probably the first to hear about it, but the new guidelines for asthma management were released today by the American Academy of Allergy. So we're right on the, Ellis, we're right on the cutting edge. No one has talked about this but us on BlackDoctors.org. So with Dr. Esteban Bouchard, we're going to talk about not only his work with asthma, but also how we're expected to treat it now under the new guidelines. But first, Dr. Donna Carey, is she, I don't see her on the screen.
Yes, she is.
Hey, the red glasses. Red glasses.
First impressions are always important, Doc. First impressions are always important.
Yes, this is a great accessory, my glasses.
I've been going to sight for sore eyes. I've been going to the wrong place. We want to welcome Dr. Donna Carey. Like I've said, she's an outstanding physician with a great reputation in the Bay Area. She's a pediatrician. She has her own projects, media projects, Walking with Donna, Talking with Donna.
Wait, he was drinking with Donna too. We
We're doing everything with Dr. Donna.
There is no drinking with Donna.
There is no drinking. It's just talking with Dr. Donna.
She's going to be our co-host. She's going to help us select projects that you like. But most of all, I want you to realize that this is your program. This is a chance for you to ask questions. And later on, first we're going to talk about where we are with Corona, and then we're going to talk about the whole issue of asthma and how things have changed. So, Dr. Carey, tell us where, one of the problems that people are having, and one of the problems I didn't think I was going to have, is I got friends of mine calling constantly to try to find out where they can get a shot. They're not avoiding the shot. They want to know where they can get it and why has the rollout been so slow, and what can people do who really want to get that shot?
Right. Well, the slow rollout is quite disappointing. Only about a third of the vaccines have been utilized in the United States. In California, only about 30% of the vaccines that we were expected to receive, we actually received. And that's across the country. So no state really got the full doses that they were expecting. And that is because of the fact that our federal government, our president isn't interested in working at the moment. And so really there wasn't a great plan put in place. And so we're slow, we're behind the ball in terms of vaccinations. We had hoped that by this time next year, we would have at least vaccinated 70 to 85% of the population so that we could have herd immunity. And we're probably, we're a few months behind that now. And before we actually reach herd immunity, it might be not until 2022 until we have enough people vaccinated to get that herd immunity. So very disappointing. The good news is that we do have vaccines, and a lot of the health care workers, frontline workers have been vaccinated. That's who was slated for tier 1. So tier 1 was the frontline workers, the doctors, nurses, respiratory therapists, all of those people who are actually hands-on to patients. And so a good majority of those people have received the vaccine. So that's good news that our healthcare workers are protected.
So,
go ahead.
well, I was just going to ask a follow-up question. Do you think it was a mistake to, and maybe mistake is a hard word, but do you think it was a mistake to leave it up to the states, or should that have been more centralized in terms of distribution of the vaccine?
You know, when I think about how the coronavirus rolled out, we have national, we do vaccines for like the flu every year, and that's state by state, county by county. And we do a really good job of vaccinating. So I don't think it was a mistake to allow the states to focus on doing it. But I do think that we needed more, the states needed more of an infrastructure for these particular vaccines because of the specialized way in which they needed to be cared for that states didn't already have. We didn't have the freezers that are needed for these vaccines. And so the federal government needed to assist in that way. But in terms of doing a vaccination campaign, I think the states were really more than capable of doing it, but needing some help in the infrastructure of, getting those vaccines, storing those vaccines, and then distributing the vaccines.
But don't you think, Donna, this is one of those big mistakes that many of the states don't have a public health structure,
right?
Like we do in California, and so consequently, when they get all the vaccine stuff, then that meant that they really weren't able to do all the things that they needed to do to get the vaccines out. It requires organization, because validation, so that people know when they got the shot and when they get the next one. And I don't think most of the states have been overwhelmed with just dealing with coronavirus.
Right.
It really should have been more federal program.
Yeah, I agree with that. I definitely think that the federal government had a role to play in supporting the states, and those states who have a great, robust public health program probably could have had a lighter touch, but states that didn't have such a robust program needed more assistance. So I think the federal government really just dropped the ball on this one.
And all of my friends are calling me now to try. I thought the big problem was going to be that African Americans didn't want the shot.
Right.
What I'm getting now is I'm getting a whole variety of my friends calling, trying to figure out how they can get the shot.
Right.
What would you recommend for people across the country in terms of trying to figure out how they're going to get this shot?
Yeah, so the good news is that in addition to the public health departments and hospitals actually getting doses of vaccine, that we're also going to have pharmacies like CVS Pharmacy is going to have doses of vaccines, and that's going to help to distribute the vaccines. And so people are going to be able to get the vaccine once it's their turn. But the key is that once it's their turn, so everyone sort of has to wait. There is a rollout in who is getting the vaccine first. So right now we're in phase 1. It should be basically healthcare workers. Then it's going to be people who live in congregate settings. So, older residents who live in nursing homes, skilled nursing facilities, and in the state of California, actually, even those who are incarcerated got moved up because they live in a congregate setting. It's very easy to spread. And so after we see the first tier, then we're going to move into the second tier. And the second tier includes people like our teachers. They're included in our second tier. Other essential workers, the restaurant workers are included in the second tier. Those who have pre-existing health conditions, they're going to be included in that tier. And then finally, we'll move to the tier where it's just healthy Americans will be able to get their vaccine. So you sort of have to wait your turn in order to get the vaccine.
But let me ask you this question. How long does it take before you actually have immunity? I mean, one of the problems that people think once they get the shot, they can kind of walk out and prance into the grocery store, prance into
have superpowers.
It takes a little bit more time for you to develop that kind of immunity, doesn't it?
Right. Yeah. So I think that both the Pfizer and the Moderna have said it's going to take anywhere between 2 to 4 weeks after the second dose of the vaccine to be fully protected. So even after you get the vaccine, it's going to take, somewhere between a couple of weeks and a month or so until you're really fully covered.
Our special guest today is Dr. Donna Carey, who will ultimately be one of our co-hosts. We're talking about where we are with this vaccine rollout. We're all a little disappointed about the speed involved in it, but obviously this is a big operation, and so consequently we can expect some kind of rollbacks, some kind of slowdowns, and not necessarily a smooth transition. What about children? What about teachers? You had a very good discussion the last time we talked about how schools are going to deal with this. What about vaccines for teachers?
Yeah, so teachers are in the second phase of the vaccine distribution after healthcare workers, those who live in congregate settings, and those who are older that have already, comorbidities like heart disease or diabetes. Those are going to be that first wave of people. And then teachers are going to be in that second wave. And I think that once teachers get vaccinated, then we really should be able to start reopening our schools, even though our children are not going to be vaccinated. Because like I said previously, for those of you who may have caught that program, but if you didn't catch the program, I'll recap here, in that there were a number of studies that were out of Europe that children who are less than 10 do not tend to spread the virus from child to child, that the transmission of the virus is really adult to child. So that if our teachers get vaccinated, then that should provide some sort of reassurance to parents to say, okay, continuing in small pods, continuing to social distance at school, continuing to be outdoors as much as possible, that then this fourth element of having the teachers vaccinated, that perhaps most of our kids can then return to in-person learning.
Well, that's a lot of good information. Have we gotten Dr. Esteban Bouchard in yet?
Oh yeah, he's here and he's ready to go. I do have one question before we bring on Dr. Esteban is, what are all those medals behind you?
So this side, right? So I do half marathons, and I do it with actually my best friend, who is still on a mission to do 50 half marathons. And so I join in with her whenever I can. And so most of those are my half marathon medals. And then my son was jealous that I was showing my medals. So he came and put his basketball medals on top of my medals. So not all of those are mine. Some of those are my son's.
I didn't realize that I could put up my 26-mile marathon medals in the background. I'm a little embarrassed by this, but Dr. Carey, thank you for agreeing to co-host our program, and I'm sure that we'll be a much better project because of your involvement. And so keep safe and get a few more medals. That's not.
I know I'm slacking off. It's been tough this year. No half marathons.
Look, I know we'll be the healthiest program now that we have Dr. Donna with us, most physically fit.
All right, so now we're going to move our program. Thank you, Donna. We're going to move our program into our asthma discussion. What's paradoxical about today is that today the American Academy of Allergy, Asthma and Immunology, released its new set of guidelines about how to actually treat asthma. And so we're going to have a full discussion about some of the pathophysiology, what we call the way in which asthma develops, especially in ethnic groups, and then talk to you a little bit about treatment. So if you've got questions about your asthma, now's the time to get in the chat room, because this program, as I've said many times, and maybe you don't believe me, is for you. So that if you have questions, then we're going to be able, at least we're going to try to answer most of those questions. So let's go first with Dr. Bouchard. Is he in the area?
Yes, hey, good evening.
Let me introduce my friend, Dr. Esteban Bouchard. He has probably one of the most amazing biographies of anybody I've ever worked with. He grew up in San Francisco and as a Latino American, raised by Chinese foster parents. He was a street guy for a long time. And you can tell me if I'm not being accurate. He was a street guy for a long time until he went to a high school in San Francisco and met a couple of African American wrestling coaches. He then became the all-city wrestler and a wrestler for most of his career. He then went on to go to, did you go to Harvard or Stanford? Which medical school did you go to?
Stanford.
Went to Stanford Medical School, went to Harvard for his training, and is probably the youngest full professor with an endowed chair at the University of California. Much of his research has been in asthma and certain asthma in certain populations. Dr. Bouchard, my friend, I am an admirer of yours. Welcome to our program.
Thank you very much.
Tell us a little bit about how you got involved in studying asthma in specific populations.
Well, I started doing research in college, and then I did genetic research in medical school as part of a medical scientist program. And there I started seeing lots of patients that had lung disease, and it was particularly research on organ transplant, heart, lung transplants. And I was getting tremendously valuable skills that it really didn't inspire my passions and why I wanted to go to medical school. I'm from the Mission District. I've seen health disparities. I've been a patient at San Francisco General Hospital, which is the low-income hospital for the city. And when I got to Harvard, I was asked and challenged to take my genetic skills and apply it to a research project looking at asthma severity between African Americans and whites. And once I got involved in that, we identified a gene that was associated with asthma severity, and it was 40% more prevalent in African Americans. And that's exactly where I fell in love with the project, because for the first time in my life, I saw with my own hands how some of the health disparities that we talk about are related to genetics or biology. And that was a love affair that started in 1997. And today is January 5th, 2021. So it's been an ongoing affair that has led me to all over the world to pursue why are there racial differences in asthma.
Now you took on the challenge. You noticed that that in the Latino population, that Puerto Rican males in New York City have 8 times the mortality rate of other Latino males anywhere else in the country. And so you were able to distinguish between Hispanic groups and define a genetic change, which really revolutionized a lot of the things that we've done since that time. Could you tell us a little bit about that?
Yeah, that was fascinating. You know, we found this gene associated with asthma severity in African Americans. It was 40% more common. And at the time, the Center for Disease Control looked at asthma prevalence and severity in the United States amongst Hispanics. And they found that Hispanics that lived on the East Coast, as particularly in the Northeast, had a 3-fold higher mortality than Hispanics in the West, the South, and the Midwest. And this is where diversity at the table comes into play, because I knew that Hispanics in the East Coast are primarily Puerto Rican, Dominican, and they have a lot of African ancestry. And I knew that Hispanics on the West Coast were Mexican and have a lot of Native American ancestry, but less African. So when we took the data from our first study and applied it to Hispanics, we hit a home run. And it was amazing to me because we had the leaders in the field that were all white looking at these data, and they were scratching their head. And within 2 seconds, I knew that it was genetic ancestry. And 23 years later, we're right. And we've identified many genes associated with ancestry that are risk factors for severe asthma and low drug response.
So tell us a little bit about the work that we've done with African Americans.
So with your help and others in the East Bay, that we recruited one of the largest studies of African American children with and without asthma. Also Hispanic children from around the nation. We looked at air pollution and socioeconomic factors as well as biologic factors and found that there's an interaction with your environment. You know, if you are in a neighborhood that is ridden with air pollution or crime that leads to stress that makes clinical disease like asthma more problematic than if you are in the suburbs.
But one of the things that was interesting is that when we did the genetic studies on self-described African Americans, pretty much all over the place, aren't they?
Yes. You know, African Americans are not a monolith. They're a beautiful mix of historical, social confluences that drove African Americans to have ancestry from European ancestry, Native American ancestry, and within African Americans, there's a large range. So, for example, President Obama, my favorite president of all times, is half African and half white. And you have to ask yourself as a physician, is he African American or is he white? And that's actually important for many of the clinical parameters that we use to measure in medicine.
So I make the statement that even though every day 10 people die from asthma, that asthma is one of those diseases that absolutely can be controlled. And so if you or your child are not controlled, obviously there may be a situation where you're not getting all of the information you need. New guidelines came out today. What was the difference between the new guidelines? You know, we've had guidelines since 1997, 2002, 2007. What's different about these new guidelines that may help people who are listening to us with asthma or looking at us with asthma to better control their problems?
Well, there are many new drugs out there. The reality, though, is those drugs are very expensive and fiscally out of reach for most populations. The guidelines are great if we adhere to the guidelines, but the reality is healthcare situations often are overstretched, particularly in this time of COVID, in which people are just getting the bare minimum with respect to what are the guidelines. And this is why we continue to study commonly used drugs like albuterol. It's the most commonly used drug for asthma worldwide. Whether you're rich or poor, if you have asthma, you're going to get albuterol. And that's a rescue, a short-term rescue medication. Then we'd like to study long-term steroids, which are very beneficial, but also very expensive. And then the new biologics are on the order of $6,000 to $8,000 a month and out of reach for most families.
Well, we have on our program today, Dr. Esteban Burchard, an adult pulmonologist. I am a pediatric allergist. We all have a tremendous amount of experience in treating asthma. If you got a question, we want you to get in the chat room and ask those questions. We always call this, Mr. Ellis, the least expensive, not the cheapest second opinion in town, but I think there are lots of people who are out there suffering, and seriously, unnecessarily, because they don't really understand the ways in which they're being managed. One of the things about the new guidelines that people need to understand is that they have decided that if you use a combination of an inhaled corticosteroid plus a short or long-acting beta agonist on what we call a PRN basis, a regular basis, you have better outcomes. And so consequently, those of you using Advair and Symbicort and Dulera, these are drugs that, well, not Advair, but these are drugs that can be used on a PRN basis. And that seems to be one of the changes in the major guidelines. You don't want to forget the reduction in triggers. You don't want to forget the fact that you have to adhere to the things that your doctors are telling you. But I personally believe in my own practice, and I'm not unusual, we have less than 5 patients admitted to the hospital every year unless they're small children with infections. So if you've got questions, tap into the chat room. Mr. Ellis will get those questions for us. Dr. Esteban Burchard, one of the most famous pulmonologists, yet I say in the world. Would I be exaggerating, Dr. Burchard?
I think so, but my mother would be proud of you.
All right. Good. You got any questions yet?
We do have a question. This question is from Michelle O'Shea. There we go. Are there any natural remedies for asthma?
There are a lot of natural ways to approach asthma, and from a holistic perspective. That means the first thing you have to do, Michelle, is to identify those things that trigger you or your children's asthma and get rid of those. Probably a lot of times your doctor will estimate, but I think sometimes if you've got a history, maybe a few allergy tests will tell you. When we talk to people about how to manage your asthma, what an action program looks like, especially for children, is to identify the triggers and eliminate those first. That's the most holistic thing that you can do. I don't think that there are necessarily any, well, let me just say it this way. I believe in both traditional and non-traditional medicine. And if you've got a non-traditional practitioner who thinks he's got a way to manage your asthma, then I think that's a way to go. I believe that the medicines that we have right now are so powerful that no child should miss much school, no one should be in the hospital with asthma, and certainly no one should die.
Dr. Bashar, do you want to add anything to that answer?
I agree with Dr. Lenore. It's a travesty when people are hospitalized or die from asthma. It's an unnecessary consequence.
Yeah, I think one of the problems that we see, Esteban, is that we see a lot of people who use albuterol as their primary drug for taking care of asthma. What are the dangers in that?
Well, tolerance is the number one danger, and reliance. And when we look at what causes asthma, it's essentially a hyperimmune response in the airways. And albuterol opens up the airways in the short term. But what we really need is long-term steroid suppression of inflammation that will come from inhaled corticosteroids like Advir, Symbicort. That's where we need help. People get addicted to not addicted, it's not the correct word, but they become reliant on albuterol when the steroids are actually the bigger players.
Yeah, I think when people talk about albuterol, one of the things that they don't realize is that if you use albuterol as your primary drug, you have much more chance of being hospitalized, in the emergency room, or even dying from asthma. Because albuterol is what we call a rescue medicine. It opens up the airway regardless of what closes it. And we have so many other medications that are available. But to go back to what our first caller, our first participant said, if you can identify the triggers, that's the first thing. But if you're still having problems, then there are lots of really good approaches to managing your asthma to the point where you can get some relief and gradually reduce the medication. I just think when we see patients that are having a lot more difficulty, it's because they're overutilizing albuterol. Mm-hmm. I would say to you that a person with mild to moderate asthma has as much risk for dying from asthma as someone who's very severe. Because once they get into a situation and they start to have problems, then they are more likely to not be ready for that problem. Most of the unfortunate circumstances in which I've had to deal with asthma like that were because people weren't prepared. And so I think this is now the time, this is now the space. We understand the disease much more than we did before, so that if you're wheezing and coughing and using your albuterol spray inappropriately, then you're missing the boat on this. You have anything else there, Alex? Alice, you have any more questions there?
Oh, we do. We have a question here from Davida Graham. She says, at what point should an asthmatic see an allergist? Many of my patients have never seen an allergist.
Well, I'm glad you brought that up, Davida, because I believe that for doctors, somewhere in your medical school training, you either believe in allergy or you don't. If you look at children, for instance, 60% of children who have chronic asthma have some allergic problem. And a lot of adults who have asthma, even those that have entrenched asthma, have never been looked at by an allergist. So I think it's just another piece of the puzzle. I think whenever you have a child who is doing what you say, who is taking care of business the way you suggest, and the problem is not better, then that's the time to see an allergist. I think that that's just another piece of information that you and your doctor can use to see if you not only can control the problem, but if you can reduce the need for medication. Nobody starts a medication for asthma without a plan to stop it. If your doctor keeps giving you albuterol, 9 or 10 refills, that is really not the approach that most people should take.
Dr. Bashar, did you want to add anything to that answer?
Yeah, I agree with Dr. Lenore what he said. The reality is that many low-income kids nationwide and worldwide rely on albuterol as the only medication that they have. And that is really a travesty when we are such a wealthy nation and we could do better.
I think that if you look at the statistics, that African American child is 3 times more likely to die from asthma. African American women have the highest mortality rates in the country, and I think that that's because we're not getting the information you need. If you're continuing to wheeze, continue to go to the emergency room, continue to have problems, then you need to change. You need to get into a system that has better statistics than the ones that you've got.
Here's an interesting question, and it's coming from Sheila, and she says, do you find a correlation with asthma and those individuals that have an intellectual disability?
I can answer that question, as I guess I'm answering most of them. Most people with that chronic asthma have intellectual disability because they don't do what they're told to do. They don't have an action plan. They use albuterol inappropriately. But I don't think that for children who have disabilities, they're more likely to get proper treatment than you are, those of you who are intellectuals. The biggest problems that I have are not necessarily, we're always talking about people in urban inner cities, how they don't follow this or that. That has not been my experience. And I practice in urban inner cities for a very long time. Most people in urban inner cities, if they trust you, will do what you tell them. Where I have the biggest problem are from the Xerox executives, the California faculty. I mean, these are people who do whatever and doctors. Believe me, doctors who take care of their own children with asthma are one of my biggest problems because they don't know how to deal with the disease. They use all kinds of medicines, and by the time we get to them, they're a mess. So I don't think the children with disability, I think they probably are more likely to get good treatment because they will do some of the things you tell them to do. Where I have the biggest problem, and those of you who are out there know that you're in that group, is because you have your own philosophy about how to do it until your children start wheezing and coughing, or until you start wheezing and coughing and end up in the emergency room, then you're more likely to be receptive.
Mm-hmm.
We got this question from Michelle, and she's asking, would a humidifier help with people with asthma?
What do you think, Dr. Bashard?
I think it's fine. Humidifiers work great. I think an air purifier would be just actually better, and it's been proven that it's able to reduce air pollutants in the air even within a polluted city. Having a purifier in the room will help.
Is there any, and this is a question for me, because I've always, I grew up in a home where my father would sit on the couch and smoke cigarette after cigarette. And so I know there is a correlation with childhood asthma and exposure to smoke and smoking. Is there any point that you grow out of asthma? Is there a way to grow out? Because I know my kids have had, they call it childhood asthma, but now they haven't had to deal with the humidifier or with the albuterol or any of the treatments or breathing treatments that we used to have to give them when they were younger. Now they're not. So do you grow out of it, and it's just as you get older and your lungs become healthier and stronger?
A significant proportion of people do grow out of asthma. but then significant people maintain it throughout life. And even in adulthood, there's a confluence of what we call overlap syndrome of asthma and emphysema. And that emphysema could be tobacco related or it could be occupational related. And they look almost identical as far as clinical presentations.
Yeah,
Dr. Moore?
Yeah, we used to tell people that if you had asthma, it was a disease without consequence. That meant if you weren't treated appropriately, that you could gradually outgrow it, or that if you were treated, there would be no consequence. But now we see a lot of people who are in their 50s and 60s and 70s who have chronic obstructive lung disease, where the only risk factor was not smoking, but asthma. And I would like to go back and talk about secondhand smoke. There's no evidence that if you smoke outside or if you have secondhand smoke exposed to either your family or your children, that reduces the incidence of asthma. Any smoke around children or adults with asthma creates a problem. But I do think that if you start talking about how we look at asthma now, we don't look at it as a disease without consequence. If your asthma is not well controlled, you're using a lot of albuterol, which is really not a maintenance medicine, then you have a greater risk for developing chronic obstructive lung disease or emphysema.
Well, the questions are coming in fast. So I'm going to fire these off.
Let's keep rolling.
Fire. We got some good questions from our audience. What are the most successful treatment options for asthmatic patients?
I can start with that. You know, there in the last 5 years have been some breakthrough medications. One of the most successful ones is dupilumab. These are great drugs. They're called biologics, but they're very expensive. And if I had a child with asthma and I could afford it, I'd definitely get them on that.
Yeah, I would say I'm a little bit more directive. I guess I've run out of patience. Most people who have bad asthma are not doing what their doctors told them to do on a regular basis. And so if you've got uncontrolled asthma, you're probably using your controller medicines, like the QVARs and the Flovents. You're using them irregularly, but you're grabbing a hold of that albuterol. In my office, I am the only one that can refill albuterol, because that is the only way for me to know how well controlled you are or not. And if you call me from Chicago and say, I don't have my albuterol, and I look at my chart and you haven't made your appointments and you haven't adhered to the regimens we talked about, shared, agreed to, then I'm going to send you to the ER, of course, but I'm not going to refill your medicine. So I think one of the biggest problems with control is that people don't get on a regular project or a regular program so that we can go back and reduce the need for medicine. My first question to people who are not doing well on the medicine that I prescribed them is, did you take the medicine I prescribed you? That's the first question. Because in the long run, that tends to be the answer, tends to be no.
All right, here's the question. What is your perspective on people or kids with asthma getting the flu shot?
I think it's critical that everyone get the flu shot. We know that viral infections like the flu are major triggers for asthma attacks or making asthma worse.
I agree with that. I mean, any viral infection that you get, if you have asthma, is likely to trigger twitchy airway and cause problems. I would think that anybody who's themselves or their children have chronic asthma would get any kind of shot that would reduce the exposure to viral infections.
All right. This is probably a question that's right in the wheelhouse. I'm throwing it right down the middle. Could mold in the home cause asthma or other respiratory issues?
Definitely, yes. That's actually a major cause of respiratory symptoms and even fatal disease. Aspergillus tends to be the mold that's most common. Black mold causes significant respiratory diseases, whether it's making your asthma worse or in individuals that don't have asthma, adults, they have allergic reactions that can be life-threatening.
Absolutely. Here's a question from Danny. He's asking, why do adults contract asthma later in life?
There are a variety of explanations for that. Asthma is part of a syndrome of what we call atopy, that includes allergies, food allergies, skin allergies, as well as airway allergies. And those could be subacute or may not necessarily be labeled as that as a child and could manifest later as an adult. So that's definitely something that we see. There's also occupational related asthma. So amongst particular industries, particularly food industry where they're processing crabs, they could develop allergic reactions that are analogous to asthma.
Yeah, one of the things that people don't realize is that asthma is not one disease. Asthma simply means reversible airway disease, characterized by certain cellular infiltration and mucosal edema. But there are lots of different pictures. For instance, young children between the ages of 6 months to 2 years can have asthma every time they get an infection. And then after that, there's no problem. Then there are children with allergic asthma. There are children with occupational asthma. And there's adult onset asthma. And there's something called severe intractable asthma. So it's all related. The symptoms are the same, but the etiologies are very different. That's why if you've got a chronic problem, you need to get with your doctor, try to figure out what kind of asthma you have so that proper treatment can be implemented. Nobody starts the medicine to keep the medicine going. We start the medicine to control the problem. We use the information to reduce the need for medicine.
So here's a question for the parents that might have a small child and what are some symptoms, some early symptoms, some signs that they can notice that maybe they need to take their child in to a doctor and have a conversation about them potentially having asthma? What are some of those signs that parents can notice to have to bring their child in?
So severe recurrent respiratory wheeze is the precursor to developing asthma. We can't confidently diagnose asthma until in the age around 4 or 5, but prior to that, severe recurrent severe respiratory wheeze is an indicator.
Yeah, the most common symptom in young children is coughing. Coughing with exercise, coughing with infection, coughing when the child's at night especially. A young child who consistently coughs without fever or without any other symptom is very likely to have reactive disease. One of the things that we do often is we use albuterol as what we call both a diagnostic and therapeutic trial. By that I mean if a child's chronically coughing, and we start them at night on albuterol and that coughing starts, that's almost an absolute sign of asthma. The most common symptom in young children with asthma is chronic cough.
Okay, well, I think we may have run through to the end right now, but they have been thinking, you've been answering some great questions here. So I think that the important thing for people to know is to monitor what's going on. I think that the allergy situation, I'll speak personally. I realize there are certain foods that trigger my coughing. And I had to kind of start avoiding it. Was it the food or was it the seasoning specifically that caused my coughing? There are some seasonings that if I sprinkle it, if I'm trying to some Cajun seasoning, if I sniff it, I'll start coughing profusely. And then every once in a while, if I'm exercising, if I run too long, too hard, I notice that afterwards I'll have a kind of a coughing episode. Those are some of the things that we do have to notice in ourselves and make sure that to Dr. Lenore was talking about earlier, what your triggers are. And if you can identify what your triggers are, not in terms of avoiding it, but just being prepared for, avoiding those foods. So I know, hey, I don't need that seasoning. I can work around that seasoning in order to get the desired result. But we do have to recognize what our triggers are.
Yeah, well, I think that's a very important component. I think most of the time, unlike Dr. Bouchard, he's got CT scans, MRIs. Allergists just usually have the history. And a history like yours would suggest that you need to stay away from those things that cause you problems. Some of the places in Europe, they really do a lot of investigative stuff when it comes to food and asthma. And it's important to note that in children, especially, wheezing is a very late sign of asthma. I mean, when you start wheezing, you have what, 60, 70, 80% airway obstruction, Esteban?
Yeah.
You have a lot of airway obstruction. Okay, so if I send you to Europe and they do all of these studies and they say, well, you know, you're allergic to kidney bean, or heaven forbid, red beans and rice and beans or whatever it is. And no, I'm serious, you're allergic to these things. The only thing they can tell you is what? What can they tell you? Don't eat it. That's all they can tell you. You need new medicine to make you able to eat greens or kidney beans. If you notice that a food causes your problem, the only thing, especially if it causes you to cause wheezing, if it's really serious wheezing, you need to look for nuts and seafood is the worst. I mean, when I tell a patient, an adult patient, they're allergic to seafood, man, we both start crying. They don't want to believe it. I know they're going to sneak back. I'm telling you. I know they're going to sneak back and try to eat shrimp or crab.
We gotta have our shrimp, Dr. Dog. Gotta have our shrimp. I'm sorry.
They're going to be back in the emergency room. Two things that make people avoid them. One is foods, the other is animals. I've never seen anybody give up an animal. Never. I've seen people in the intensive care unit, and I've seen people, and in fact, I get on my granddaughters because the dog has replaced me in a hierarchy of things for them. I don't understand. I don't like animals. I don't want them on coats. I don't want them experimented on. But I have never seen an allergen like that, where people will take serious symptoms to keep up with these animals. And so consequently, I think a lot of what you do about controlling your asthma has to do with the decisions you make.
Last question. Can you exercise your way into having to lowering your asthma response?
I don't understand the question.
Can you with better exercise, like running, more physical exercise, will that help reduce the asthma attacks or incidents or episodes that you have?
Well, you know, there, like Dr. Lenore said, there's different flavors of asthma, different types, and there's exercise-induced asthma. And that's where it's probably better for you to take albuterol before you exert yourself. And what ends up happening is people continually push themselves to that line without taking their medications, and they become poor sensitizers. And this is where you might see an asthma attack on a football player in the field and they have a cardiac arrest. And that's where it's very important that you follow your care guideline with your physician and you have an action item and plan in place.
I think it's important to realize that a lot of asthma with exercise is just poorly controlled asthma manifested by exercise. So people say, well, I only have trouble with exercise. But if you start to talk to them, they have trouble with other things. They have other problems. True exercise induced asthma is asthma that occurs after exercise is over, not during exercise. And so if you have trouble during exercise, you really need to talk to your doctor about the possibility that you may have ongoing asthma. And that needs to be managed so that you don't get in trouble with exercise. All of the children that I've lost with asthma were kids who have had what they call exercise-induced asthma. They went on a football field, a baseball field, basketball court, and got into trouble because they were not prepared to deal with asthma when it hit. And that's been the biggest problem. Those people those people who are listening to us with very serious asthma, no. They got everything. They got machines. They don't want to go to the emergency room. They have everything. The people that die from asthma are those that don't recognize the severity of the disease and are not prepared.
But that's the run of the questions for tonight.
Okay.
What I All right, well, then we would like to would you like to make a final statement, Dr. Bashard?
Well, I think asthma is a very important disease. It's actually the most common chronic disorder in children. And it's the one disease that has significant racial differences in prevalence, severity, and mortality. And I think it's incumbent on the National Institutes of Health to focus their attention on this particular disease.
All right. Well, I have a lot to say to finish this up because really I've been in this business for almost 35 years, and I've seen a lot of unnecessary, what we call morbidity and mortality. The first thing that I think you have to do if you or your children have asthma is to identify your triggers. Either you can do that from your own experience, or you can get an allergist to help you to do that. And eliminating triggers can really make a big difference. The second thing you need to do is to find somebody who knows what they're doing. I mean, you may be in a clinic or in a doctor's office. He may have no idea about how to manage asthma, and so consequently, you become a prisoner in that situation. You don't want to leave because he's nice, got a good bedside manner. You need to find someone who knows what they're doing with asthma. You need to get as much information as you possibly can. There's the Asthma and Allergy Network, which has wonderful information about asthma and things that you can do. Finally, there's something called, Esteban, we can't call it not taking your medicine anymore because that's politically incorrect. We have to call it adherence. But if you don't take your medicine the way you're supposed to take it, then there's no way in the world I can help you because I won't know what you're doing. So if you get somebody, you know your triggers, you get somebody who knows what they're doing, and then you take the medicine on a regular basis, then I can reduce it, or Esteban can reduce it. But there's no reason in this world why 1 out of 30%, one of every 3 children with asthma is an African-American child who dies, and Black women who have so much to do to try to take care of the health of other families have the highest mortality rates. We've been fighting against that for years, and we will continue.
Absolutely. So we got one last question here from Danny. He just asked, what's a normal time of treatment for a problem before you should ask to see a specialist?
I think personally, when, as Dr. Lenore alluded to earlier, when symptoms become persistent and start getting out of control, it's a good time. And if you have a doctor that doesn't know what they're talking about, then it's easy to request a referral to a specialist.
And I agree. So I guess I should thank everybody now, Alice. I'd like to thank Dr. Bashard. I really want to say that Dr. Bashard is one of the most outstanding researchers and physicians in his field. I'd like to thank Donna Carey for agreeing to join us. I'd like to thank you, Alice, for putting all this together. But most of all, I'd like to thank our audience for joining us. This is a place where you can come and get your questions answered. And remember, health is your biggest asset, so protect it.